Good afternoon. I'm M.VISSER and I am from South Africa, and I'm going to change the topic a bit because there's a lot of psychiatric talk and a lot of psychological hospital evaluations as well. I'm going to focus much more on the community intervention and on the more social aspects of it. South Africa is in Africa. It's in the southern point of Africa. And we battle a lot with services, all kind of services. There's almost very, very few psychiatrists. Psychologists battle, we cannot get everything done. We rely, at this stage, we have a whole task shifting approach in health to use auxiliary workers, to use mental health education people with almost no education, educated specific or trained for the specific task. So that is where I also focus, to get people to get the job done, because otherwise there's just no services available. I want to talk about a family-centered intervention for children affected by HIV. This program is for caregivers and adolescents. Our country has a huge HIV problem. There's 6 million people infected, and it's 12% of our population. That means that we have a lot of, it has an impact on the families, because parents get ill and parents die. At this stage, there's more than 2 million orphans that there's no real facilities for, so they are being taken care of in extended families. It's all the grannies, or the aunts, or another family member that take care of them. But there's quite a lot of money pumped in to develop programs for them, because they cannot be taken care in a formal setting. The other problem is that HIV-affected or HIV-infected caregivers, the parents, cannot parent as usual, especially when they get sick, because the mother has other issues. There's a high level of depression among the mothers with HIV, and then their parenting skills go down, especially if they get sick, and that has an effect on the children. So that is the population that we work with. There's evidence of multiple risk and negative mental health consequences of parental HIV and being orphaned by AIDS, and children and their caregivers. There's a lot of data, so I'm not going to say everything. There's a lot of psychological issues among the children. There's psychological issues among the caregivers, the parents, as well as the grannies taking care of the children. And there's also a very high risk of HIV in this group because of the psychosocial issues that they deal with. This is on parenting, and the research also say if you got positive parenting, then you have a possibility that these children can overcome many of the problems and that they can grow up as normal adults. It was found that family-centered interventions are the best, so that you can not only work with the adolescent himself and go home into a very dysfunctional family, then the effects of the research or the effect of the intervention is not really effective. But if you can involve the caregiver in that intervention so that the whole family changes, then it's not only on the child. So you try and change the whole system there. So that is what we try to do in this intervention. For me, coming of age, I thought, what is the thing that I can do in the rest of my life that can make a real meaning contribution? I've got so many years left and I want to do something. For me, I thought, if I can change parenting in our country, I think we will have a huge effect on the youth, which is more than 50% of our population, so that they can grow up in a different environment and then they can be more healthy. So for me, that was a personal goal, but it also came from other sources. The goal of the research was to develop a structured support group intervention for caregivers and adolescents to improve their mental health, family relationships, and to reduce adolescent HIV risk behavior. We tried a very difficult thing. Okay, the theory of change. If you work with a caregiver and you help the caregiver to cope better and to deal better with their own issues, the assumption is then the mental health of the caregiver will improve. Phase 2, up there. For the caregivers, if you improve their ability to manage the adolescent's behavior and emotions, and improve their communication and relationships and also their HIV knowledge, then you will have a better parent. On the same time, we work with adolescents to improve their problem solving, emotional coping skills, expanded social emotional support, and the relationship with their caregiver. Give them some HIV prevention, help them with goal setting and future planning. You will improve the relationship in the house, which can lead to better mental health and risk behavior. So that was the plan. We tried almost the impossible, and in a way, I think we succeeded. No. Okay, next one. We developed a program based on cognitive behavior theory, and we gave the facilitators who were community workers. They had a basic grade 12 level, so they were at the end of school. And they had some experiences of working in communities, but they do not have any tertiary psychological education. Some of them had a little bit background in social work, but they were not qualified social workers. We gave them a week's training on each phase. So it was basically 4 weeks of training that they got to present this program. And I think they made a difference. We can talk about the qualitative feedback now, and the quantitative is on the way. We gave them tools, and we expected a lot of them. And eventually they reached these communities and they worked with these children so that there's some difference in the way that these children are thinking, as well as their relationship with their caregivers. We started with the first phase was for caregivers. Caregivers matter. So we worked for 4 sessions with the caregivers themselves on their own psychological issues, because they come through life. They're mostly 50, 60 years old, and they are taking care of their children's children because the parents are missing now. They're older, there's a huge generation gap, they do not understand these youngsters, they're mostly out of control, there's very little money available, so that is the setup. So we help them to deal with their own sadness, to deal with their own fears, with their anger, how to deal with your anger, and not just by shouting and allowing people to do what they want. And then there was also a session on how to manage problems. So in this 4 sessions was quite intense. They formed a group and they worked with their own emotional issues. The next was parallel sessions between the caregivers and the adolescents. For the caregivers, we focus on how to raise an adolescent. What are the issues and how do you deal with them? Effective communication. Where is that? So in the parallel here was for the young ones as well. How do you assert yourself and how do you listen to your caregiver? Helping adolescents cope with difficult emotions. So what they've learned, they look at from a different level now. Now they are the helpers. They have to help the children with dealing with their emotions. How do they manage the behavior of adolescents? And there was a rest session for them. The adolescents went to my strengths and goals more setting goals for life, effective communication, emotional awareness, coping with sadness, coping with anger, and then there was 2 joint sessions here, families working together and positive family relationships. So you try to build them up. In the beginning, we had these sessions right there in the beginning. It didn't work. They were so angry. They couldn't say one positive thing for each other. They were furious. It was a complete conflict situation. Then we moved it around so that these sessions are at the end. Now they worked through all of these and they started to understand each other. And eventually these were very constructive sessions. After the relationship improved and they could start talking to each other, solve problems, deal with conflict in the house, we started with the HIV sessions. To talk about sex is a total abandoned taboo. That's something nobody does. Well, it's not only in our culture, it's everywhere. So the parents had real difficulty. They refused. They said, no, they're not going to do it. By talking to each other, they realized that it's actually necessary. In their generation, nobody spoke to them. And there's lots and lots and lots of pregnancies. And for them, the caregivers, that was the thing in their life that they are ashamed of. So they started to talk to each other and say, probably we must do something for the youngsters. Some of the caregivers said, I've got a child who had 2 babies already, but I've never talked to them. I've never said anything. So then they started to realize that it's quite important to do that. We taught them about risk behavior and why it's necessary to talk about sex. To communicate about relationship, what is healthy relationships, and sexual health. To understand the facts of HIV, they didn't know much, although some were HIV positive. And then responding to crisis, which is usually the pregnancy in the house, the being HIV positive, the being raped. For the adolescents, we had a session on sexual relations. They were very keen to participate. They had nobody to ask. So they were extremely keen to participate in these sessions. Communication about sex, how to do that, how to say no, how to deal with sexual consent, and then HIV and STIs, the facts and the fiction, and health session on condom use, how to negotiate condom use, how to use condoms, why it's necessary. And then there was joint session again, future planning, which was a lot on pregnancy, dealing with teenage pregnancy, how to communicate about that, and then a whole thing of looking ahead. What is my ideals for you as a child, so that they joined forces there and they could discuss things. So that was the content of the program. We used other programs, but I'm not going to go into that now. Material from that. The key elements that we used. We used a support group climate so that they can talk to each other and share emotions and share experiences. We find that as a very helpful tool in all the HIV work that we do because they understand each other. We use social learning and cognitive behavior theory, which I think we were quite ambitious to do, but it was fruitful. At the end of it, the trainers and some of the caregivers could understand how it works, how your feelings, your thoughts and behavior get together, and how you can think differently about situations. We use structured sessions, activities build on each other, participative learning. We used culturally appropriate scenarios and stories which they could identify with, and I think that made a huge difference. If they hear the story, they see the outcome, and then we give an alternative story of how it could have, or they bring alternatives how they could have dealt with it. A lot of home practice, where they had to do a project together, and where they could exercise all the things that they've done in the sessions. And then we trained community facilitators, so it's not professionals presenting it, but they were quite well trained. The implementation, it was a 17-week intervention, which is very long. There were 13 caregiver adolescent groups led by trained community-based workers from 17 community-based organizations, and there was almost 130 to 150 caregiver adolescent pairs involved. And the program was presented in the vernacular of the participants. Okay, some of the pictures that you get an idea, these are the trainers, the community-based workers who did the interventions. This paper is based on the evaluation of the qualitative feedback. We had 6 focus group discussions of the facilitators of the sessions, 2 groups after each phase of the program. And the questions we asked them, the successes and the challenges, the observed behavior changes that they observed during the training or during the sessions that they presented, the unanticipated and negative outcomes, and recommendations how they suggest we improve it. So we recorded this focus group discussions, transcribed it, and analyzed it. I'm going to be brief because I can keep on for a long time.
Yes, and we do have the other presentations.
I know.
They have arrived.
They have arrived?
Yes.
Okay. The caregiver sessions, the first phase, the most important that what was happening there was trust developing, and they developed a sense of belonging. Most caregivers shared their personal and painful experiences, which they have never done before. So long time illnesses and pain, they revealed in these groups, and it was quite important for them. They shared their stories they had never discussed before. Previously, they ignored their problems and just bottled up, which resulted in them getting sick and angry. One caregiver realized that she needed to face it. She felt relieved of her burdens when she shared her experiences with a group. Other things they've learned to manage their anger, to communicate assertively, to link negative thoughts to negative emotions, and how to solve problems. The quote I want to read there that you can't see, but I can see it quite well. Caregivers felt like bad parents and useless when children behaved badly. Now they are able to separate the child's behavior from their own sense of self. In the phase 2, when the caregivers were more in a helping position, something interesting happened. In the beginning, the caregivers were very authoritarian. They didn't speak to the children unless it was an instruction or they were reprimanding the children. There was no two-way communication. The children didn't say anything. They didn't have a good relationship with that caregiver. In this training, we saw a shift in the relationship. The adolescent started to speak up. They started to assert themselves and start to say what they wanted to say. The caregiver on the other side started to listen. And then there was a more equal relationship so that they could actually talk to each other. And it was beautiful to see how they could discuss this. Now this is the summary of everything. Now I can go through this assertiveness one of the adolescents. The adolescents said, most of them really want to express themselves being assertive. Assertiveness gave them a form of power. I think assertiveness creates the space for positive communication in the family instead of being angry. Now the emotion is expressed in a proper way that one has to listen and the other has to say what they are thinking. On the other side, the caregivers started to listen. I like this program. I wish it could continue because it has bonded my family. My family was falling apart. I was not close to the children. So building this relationship with my kids, I see the difference when they are at home. I'm relieved. I don't have stress anymore because I can talk to my family and they can also tell me what they're thinking about. If I did something wrong, they call me, sit down, mother, this and this. So the communication improved in the family. They developed house rules. I'm not going to go through that. They started to talk to each other about house rules, and then the children start doing what they agreed to do. So it was not a top-down structure. They discussed family roles, and the positive communication, one of the exercises was to focus on the positive, to say something nice for a change. And that had a huge effect, that they realized that even the adolescent can do something right. And the other for the caregiver, there's not only anger in the house. And they spent some time together according to the assignments that they got. A caregiver and adolescent talked while they were doing gardening. The caregiver learned about the child's emotions. He told her how he feels and what he does not understand about losing his mother. So some communication started to happen, which improved these families. On the last one, I think I have shared quite a bit already. It was a taboo, and eventually they convinced each other to talk. And there were quite a few testimonies that they did discuss sex or anything related to sex in the household. Before, she would have shouted if she found condoms in his room, but now she sit with him and find out from him why he decided to do it now at an early age. They have conversations about things rather than her shouting and scolding him. So some communication did take place. Okay, the challenges wasn't. It was some of the caregivers that find it difficult, and they said, but you are on the adolescent side. You promote their cause and not ours. But it was not many. So many of them went along. So what made this work? I think it's because it addressed the real need. There's really a huge need, and there's no help. So it was their real family problems that was discussed. It focused on coping with their real prominent emotions. It was a structured theory-based program. It used real-life problems. It focused on developing skills to talk to each other. And they started in this relationship, they started to feel acknowledged. And I think that is what made the difference here. The conclusion is that I think a family-centered program shows promise as a cornerstone of the effective response to the HIV epidemic. And this program has the potential to be effectively implemented. The scale up now, we are busy with a pre-post data analysis, and the next step will be a randomized controlled trial to see if it really makes a difference. If you're in the HIV field, you will know that there's a huge scale up at this stage. Everybody in HIV sponsoring PEPFAR and Bill Gates and all those big names donated a hell of a lot of money to focus on girls in developing countries, so that because they have the highest HIV rate. So this program has been upscaled, and it's this year alone, 6,000 families have to go through this, and this is going to happen for the next 3 years. So it's a huge implementation, and we have a trainer of the trainers now, so we train social workers so that they can train the rest, and it's sort of taking South Africa by storm. And I hope from my side that it takes the relationship by storm as well, that there's a change in family talk and family relationships so that we can improve mental health. Done.